Good evening and welcome to Empower 2019, Frontier Nursing University's virtual Nurse Midwifery Week event. I'm Tanya Nicholson. I'm the Associate Dean of Midwifery and Women's Health, and I'm so honored to get to introduce tonight's speaker to you, Dr. Kalina Lanuza. Dr. Kalina Lanuza is a certified family nurse practitioner, and she received her Doctor of Nursing Practice degree from Frontier Nursing in 2018. She currently serves as an FNU faculty member and specializes in women's health. Her clinical and academic areas of interest include promoting emotional wellness during the perinatal period. She helped to found and co-chairs the Maternal Mental Health Coalition of Ventura County and is committed to improving perinatal mental health in her community through the use of interprofessional collaboration. Thank you so much, Dr. Lanuza, for being with us, and we look forward to your presentation.
Hello, my name is Dr. Kalina Lanuza, and again, thank you so much for the invitation to present during this virtual Nurse Midwifery Week presentation here at FNU. I'm honored to be able to share space with my nurse midwife colleagues. As you see, I am not a nurse midwife, I am a family nurse practitioner, so I'm going to talk today a little bit about how our two disciplines can work together to really move impactful change. So let's get started. I know you've heard a little bit about me. I also wanted to let you know that I graduated from Frontier Nursing University with my DNP in 2018. And at about the same time, a little before I actually applied to the program, I helped to co-found and I currently co-chair a maternal mental health coalition in my county. And I did that because I really wanted to see larger scale change in my county surrounding perinatal mental health. And when I was looking for a DNP program to be part of, that I could sort of merge all these things together, Frontier really spoke to me because they had a strong women, children, and family focus. And so when I did the program, I was able to use the tools that I already had started to build with the Maternal Mental Health Coalition, along with the tools that I got through the DNP program to put together something really meaningful. So today, I want to talk to you a little about my DNP project, not the whole thing, but the nuts and bolts of it and the highlights. And then I want to talk to you about how I used some of those tools and used them to scale up improvement in my community and beyond. So the key takeaways here are really for you to learn some effective strategies to implement best practice in the OB setting. I currently practice in the obstetric setting 1 day a week, and I think for a lot of us who are working in OB, we look at guidelines and, our schedules are so impacted, and so our job as APRNs is really looking at effective ways to really get these best practices into our clinic setting or our office settings and not really stretch our capacity beyond what we're able to do. And so we're going to go through some of those things today. I also want to look at shared decision making and how that model, when implemented, really helps empower patients and really helps empower your team. And this is a big team effort, right? Quality just doesn't ever get improved by just us alone. It's all about us and our team. And so I want to show you what we did with regard to shared decision making and how it really helped get everybody at the table and everybody really belonging to this experience. And lastly, I'm going to talk about collaboration. And we hear a lot about interprofessional collaboration or interdisciplinary collaboration. And that's a big buzzword right now, especially in education. And so I want to show you what that meant for us and what we were doing in the relationships that we forged in order to really move this project forward and then really scale it in the community. So before we begin all of that, I want to get everyone on the same page with regard to definitions. So when we're talking about perinatal mental health, we're looking at things called perinatal mood and anxiety disorders, or PMADs. So we used to refer to this just as postpartum depression. And then we would say things like, but it can also present in pregnancy, and it can also present as anxiety or OCD or bipolar or PTSD and rarely postpartum psychosis. So now what we've done and what we're starting to do and what you're starting to see in the literature is we're stopping just postpartum depression as the word, and we're using what it really is. It's an umbrella of disorders, and it can happen in the perinatal period. And we define that as any time between in pregnancy and up to a year after birth. So as you can see, that's almost a whole 2-year span there, where you can have any one of these disorders that are in the orange down below at the bottom of the screen. And nationally, we see these disorders occurring in about 1 in 7 women. In my state, we have a large state. We did some analysis a few years back, and we found that it happens in about 20% of all patients, perinatal patients. So 1 in 5 women. And then women of color have a higher rate. They're at about 38%, or about 1 in 3. So that makes this the #1 complication in the childbearing process. And as APRNs or aspiring APRNs, we know that, what's our job? Our job is to fill gaps. It's to improve care. So clearly, if we're having this #1 problem, we need to attack that. We need to get these numbers lower, and we need to improve lives, right? So welcome to my neighborhood. I live in Ventura County. It's a county that's nestled in between Santa Barbara and Los Angeles in the Southern California region. And in my county, we have approximately 10 cities and a few unincorporated areas. We, at last count, have a population of about 844,000, just a little over. We also have a large migrant farm worker population, so these numbers are estimated to be a little low, just because of lack of self-reporting. We have about 10,441 live births in 2017, to be exact. So that's us. That's what my community is working with here. Now, I put this screen up here, economic burden, but when we're talking about the burden of perinatal mood and anxiety disorders and untreated PMADs, and this goes for everything that we help patients with, there's always more than the economic burden, right? There's the emotional burden. There's the strain on their relationships, their attachment issues that women have with their children or fathers have with their children when they're experiencing this. There's all sorts of things, increased, healthcare expenditure, all of that. But if you've ever done community work, you know that you need to go and talk to folks that are going to help you get some funding. And they always want to know about this slide. They always want to know about economic burden. And so here we are. And these are huge. $2.25 billion in my state is spent annually on untreated perinatal mood and anxiety disorders. And that's a lot of money. And then when you extrapolate that out and you look at my county alone, we're at $34 million. I had a recent visit with a legislator here, and when we spoke with her about the impact in our community, we brought out these statistics, and her eyes widened, and she said, "Okay, well, that's a lot." And so how can we work together? And so that's why this slide is there, but just to also sort of show you the profound, impact that this does have. So what do? We go back, we look at best practice, right? And thankfully, we have some best practice here. What do all of the folks that help us with our guidelines say? And this is just a small amount of them on the bottom of the slide here. But everybody says screening alone is not enough. We have to do it, but it's not enough. They also say that we need to treat these women, treat these patients, offer them a variety of different treatment options that have been shown to work, not just one, not just here's a pill, or here's a therapist that you can go to. We also need to follow up with them. And that's pretty clear. And that's been one of the biggest challenges, I think, in implementing best practice surrounding PMADs is the follow-up. But I say, just like we would do with anything else, if we had a woman come to us with a breast mass, we wouldn't just tell her to call her insurance company and find a surgeon that she could consult with. We'd actually make that referral. We might call them and ask them to see our patient. We would follow up with her, or at least have our staff do that. We'd get her back into care. The surgeon would communicate with us. So we do that for a variety of different things, and we need to start doing that here too. So thankfully, there's guidance, and there's really good guidance. I think that many of you that are watching this today, especially in midwifery, you've seen the Council on Patient Safety in Women's Healthcare's bundles, and they have a great patient safety bundle for maternal mental health. And what we tried to do in my DMP project was implement key components of this safety bundle to see if we we could pull this off in a small obstetric practice. And so I'm going to walk you through, kind of what we did and how we're helping to implement this. So welcome to my office. This is my tiny office. I'm there PRN, so about once a week. And I have 3 medical assistants and a receptionist. And the OB was delivering during this picture. Isn't that always the case? I don't deliver because I am a family nurse practitioner. So I just see perinatal patients and then do full-scale women's health. But that's us. That's my team. And so, like anything, when you're wanting to improve quality, you have to know what your problem is, right? And so we went to our charts, we went to, our practice, we looked at what was going on here. And what we found in a gap analysis was that only 15% of our patients, so a really small amount, were receiving screening. And those happened to be my patients because I had started this or helped start a nonprofit that was surrounding this, and I knew we had to screen, but not many of our patients were getting screened. And of those that were getting screened and all of our other patients, they just didn't have a good idea of what perinatal mood and anxiety disorders were, and neither did our staff. They didn't have a good knowledge base, so that was an issue. They also were very unaware of any resources that were available to help with this problem. And so we found that, okay, that's another gap here that we can help fill. And we were all over the place in our office with regard to standardized PMAD practices. We had none. I'd do one thing, my physician colleague would do another. And so this screamed need for quality improvement project. And thankfully, I had applied and got accepted to Frontier. So here we go. We started to make the plan while I was in my project. Our plan, we did this very methodically, of course. We utilized SBIRT. A lot of you might be familiar with that when we're talking about substance abuse, but it's screen, brief intervention, referral to treatment. We also added a little end part there, follow-up, because we wanted to get that follow-up component. But that's what we used to make sure that, we were really implementing several components of the safety bundle. In the safety bundle, what we wanted to really tackle was making sure that all women who were at risk were identified appropriately. So all perinatal women, we wanted to ensure that they were being identified, so screened. We also wanted to ensure that all of the perinatal patients that were coming into our setting had adequate PMAD education, that they were familiar with this, and that if they screened positive, we do what the bundle said to do and offer staged-based treatment options. So not just here's Zoloft or here's a therapist, but really sit with them and look at all the evidence, give them a menu, if you will, of all of the things that would work and go through those and see what might work for them. And then referral to mental health and follow-up. So before we started this project, I met with 4 therapists who I'd known through my work through the coalition. And again, you don't have to start your own coalition. There are community resources available. There are national resources available. It was just a need in my community. But I met with 4 therapists who specialize in perinatal mood and anxiety disorders and asked them if they would take my patients if I referred them. And I asked them also if they would take them within a week. I know, tall order, right? We'll talk a little bit about that later when we get into that intervention, but it surprisingly worked really well. So that was that. And then we used 4 rapid Plan, Do, Study, Act cycles, which I learned about through the Institutes for Health Improvement, and we use at Frontier to ensure that we were methodically putting into place these key interventions of screening, brief intervention, referral to treatment, and follow-up. We also, through those Plan, Do, Study, Act cycles, monitored my team because we're small and I didn't want us to get burned out. And that's one of the number 1 reasons, right? Why things start out with a bang and then they just fizzle because there's just no capacity to sustain them. So we looked at that in our Plan, Do, Study, Act cycles as well. Each Plan, Do, Study, Act cycle went over 2 weeks, and we did 4 of them. So this whole entire project lasted 8 weeks for the purposes of the DMP project, and we even went a little further after that. So let's look now. We have our plan. Let's get in there. Screening. How did we do that? And what did we do? We decided to use the Edinburgh Postnatal Depression Scale between 28 and 32 weeks, and then again at 6 weeks. And so we used this, and I'm going to show you this tool here, because in the world of perinatal mental health, this is one of the most widely used screens when you need to get some information quickly. There are better ones, I would say, but those are typically used in outpatient mental health settings where they have the luxury of having a 45 or 60-minute visit, whereas ours, as you know, are 10 to 15. So this is a pretty good test that assesses for depressive symptoms. It also, as you can see with the arrows there, number 3, 4, and 5 assesses for anxiety, which is nice and why I like it. It's a valid, reliable tool. It's recommended by almost every agency that deals heavily in perinatal mental health as a valid screening tool, so we use that. Also, number 10 lets you get an assessment of danger risk here. Are they at risk for harming themselves? So that was our first intervention. Our second intervention was our brief intervention. And what we decided to do with this, because we already had access to the Maternal Mental Health Coalition of Ventura County that had a ton of resources on their website and could print brochures and what have you for us, is we engaged women after they were screened with pads or tablets in the office settings. We have 4 rooms. Each pad was about $50 a piece. And we had the Maternal Mental Health Coalition's website pulled up already. And that's here on the left. You'll see it. And we had the perinatal mood and anxiety disorder tab pulled up. So when they were finished screening and after the medical assistant left the room and the patients were waiting for either myself or my OB colleague, they could read about these. And we also handed them a brochure. And then no matter where they were in our office, there was some form of literature. If they went to go drop off urine in the restroom, there were infographics everywhere about PMADs and who to call and what to do and so on. And that's what you see there on the top of your screen as well, the 1 and 5 blue button. So we engaged them there. And then we also, upon checkout of their visit, if they were screened, we had the receptionist send them a pre-programmed e-message through our electronic portal, which many of us have now, just with the website, again, of the Maternal Mental Health Coalition, information about perinatal mood and anxiety disorders. And so it just reinforced all of this. So third intervention here was, this is the biggest right here, refer to mental health and follow-up. So again, I was talking about that shared decision-making, right? So really sitting with patients and engaging in an interpersonal relationship and having one with a patient. And I know we all say we don't have time, we've got to do all these things, right? But as you saw in those first few screens, 20%. So they're going to keep coming back. These women are going to keep needing help and bigger things and bigger things. So if we don't take those extra 5 minutes now, we're going to see it later. And this was really key in this project. We had tried to just give women who screened positive a referral for a therapist and a support group. We had that all set up. I mentioned I asked 4 therapists if they would do this for me, and they all said yes, actually right away. But that wasn't moving patients to get care. What was when I sat with them, and I'll show you some of the tools that we used, and really engaged with them. And then they started to get treatment. And then we also, with follow-up, we decided that we were going to follow up with everybody a week after they were screened, because that'd give them enough time to either get an appointment on the books with a therapist if they were going to see one, or engage in some self-care treatment modalities, or go to a support group. So that was our other portion of our intervention here. So let me show you that shared decision-making tool. This is a menu of treatment options. This was put together by 2020 Mom and through MCPAPS, which is in Massachusetts. And as you can see, depending on the level or the severity of distress that a woman was having, there's all sorts of different things that are shown in the literature to be able to help. And so we laminated 4 of these, and we put them in each office. And if they screened positive, we just pulled it out and we said, okay, you know, let's have a conversation here. These are some of the things that might help. What do you think you could do? What would you be willing to do? What sounds good to you? That being said, if a woman is severe and she needs inpatient treatment, clearly we're not going to be referring her to yoga. But in most of my patients, you know, this worked really well, and they were able to sort of piece together what they thought they could pull off. And it was very helpful. And I'll show you a little bit later in some run charts here how helpful that was. We also got that tablet out again, and we showed them this spot on the Maternal Mental Health Coalition. And again, these are available on national websites, like Postpartum Support International has these things. Your local groups might have these things too, but we showed them a list of therapists in our area that we had pre-populated so that they could see beyond just the 4 that we were referring to. We showed them the support groups that were available in our area, and then we showed them the link to SelfCare Resources. And I'd say this is key. You know, we always say, maybe you should do some yoga, or maybe you could get a prenatal massage or a postnatal massage, and then that's all. And I will say that when a woman is in distress and when she's having a hard time and a go at this and experiencing perinatal mood and anxiety disorders, and if she doesn't already have a go-to, you know, prenatal yoga place or massage place, it's really difficult for her to take care of herself, to take care of her newborn, and go on Yelp and find a place and all of these things. So we looked for these, we vetted them, and we put them on our website. You don't have to put them on your own website, but just having these resources available, knowing who in your community does a good massage if you don't already, these things are important. And for referral, for tools, we had a referral form. It was just a pull-off form, just like all of our other forms that we have, you know, a 5x7, just on a pad, very inexpensive to print up. This is a sample one, but we had our 4 therapists that were on here all ready to go. We'd put in our patient's name. We'd scan it into their chart. We'd fax it or e-message it over to the therapist that we were going to refer to. And then we'd hand it to the patient, and we'd have them actually call the therapist or email them and make that initial appointment so that they were able to align with schedules and all of that. Also, we're a very small office and we didn't have capacity to make appointments that way. That's the front of the form, and this is the back of the form. It just had local support groups on it. And so just everything right there, ready for them. We've since added to this and put Postpartum Support International's online weekly free support group on this form as well, so they have that. And then, you know, in order to communicate with therapists or anybody else, we have to have, you know, consent, right? We have to have a medical release. So this is just an example for folks to use in Ventura County. We have this on the Maternal Mental Health Care or Maternal Mental Health Coalition's website, but just your normal medical release. We had that, and we scanned it over or faxed it over to the therapist. We had the patient sign it so that we could start a dialogue, just like, again, we would with that breast cancer patient, you know, just so that we could be in communication with them and really have this whole shared decision-making team approach to caring for these women versus just the referral. We dump you off and hope you get better and we'll see you next year for your annual. We didn't want that. So we wanted to continue to talk to them, and that allowed us to do that. So follow-up. That has, again, been the trickiest part. And so we came up with this this pretty effective, I'd say. We still use it. We use it in an electronic form now, but we use this case management log. And this lets us see, you know, who was our patient? When were they ID positive? Did they get a message sent home? Did they get a therapy referral, and who was it? Did they get an appointment? Is there an appointment on the books? And did we follow up with them? Did we call them back? So this let us see, you know, if we were really doing our job. And this also let us easily collect data about that, which is key. You have to collect data about all of these things across the board so you can see how you're doing, you can make tweaks and continue to improve, right? So this was our case management log. And all of these will be available to you. I'll let you know where to get them if you want to use them. And then because we are a small office and I only work there once a week, we really had to empower our team to be able to follow up with these women. So we made a nurse follow-up form, or in this case, our medical assistants use it. And it just walks them through little talking points of things to ask. You know, did they get their appointment? Were they able to do any self-care? Did they have any questions for myself or my physician colleague? Because sometimes the medical assistants, you know, they can only answer so much. So that was one of the tools that was highly effective in being able to track whether or not they got their call, and then a little bit more data about the call. And again, now we use this all online in our EMR, but with this project, we used all paper forms. And you can do either. So 4th intervention, this is the best one because we had food. I love food. So we empowered our team. And how do we do that? We did huddles, because when we went to the literature, weekly huddles were the thing. And you know what? They are the thing. They really work. You get together, you talk about things, you get folks involved, you ask them their opinion. they're doing a lot of this work for you, or my team did anyway for me. So asking them, how's screening working? Is that working this way, or what's better? So weekly huddles for sure. And then bringing in the food, because remember, we had a very low baseline for perinatal mood and anxiety disorder knowledge. And so we needed to learn, but you need fuel for your brain. So I bought a lot of lunch. But my team really started to learn about what these were, what to do about them. We started to decrease a little at the end of our project with regard to like knowledge, and there were a few dips. And so because I'm an educator and I've taught at the BSN level for a while, I understand the value of flipping the class, right? Students don't like it, but it works. And so we flipped the class, or I flipped the class on my staff, and I had them present perinatal mood and anxiety disorders to me and my OB colleague. And that, boom, got us right over the edge. And I would say that, you know, there are many experts now in this field, which is beautiful to me. In fact, this medical assistant that you see in this picture right here, her name is Liz, and she was a champion here. And then that's the thing about empowering your team, is finding a champion, finding somebody to take this on. And I can be as passionate as I want to be, but it won't exist the 4 other days of the week, or maybe when I leave, if other folks aren't too. So after this project was over, she said that she would love to go around with me. I lecture a lot in the county about this to different agencies, and that she would love to come around with me and help lecture and help let people know how easy this actually was to do. And that's when you know that you've got a very empowered team, when they're taking ownership of this and they want to do more. So that was our 4th intervention. And any good DMP project would not be complete without a few run charts. So I'll show you those, not ad nauseum, but I just want you to focus in on those highlighted areas. Shared decision-making. So this is our patients and their engagement and their knowledge. We gave them a website. We posted brochures. We were starting to get some feedback. They were starting to understand things more. But when we started to really give some ownership to them about what was going on with them and asked them to engage in a shared decision-making model with us, that's when these women really started to really become more engaged, become more knowledgeable about this. And then we also had another opportunity with our OB patients. We're still seeing them, right? We saw them at 28 to 32 weeks. If they screened positive, and if they didn't go and, you know, maybe do some self-care, or didn't go and see a therapist or a support group, we found other opportunities during the course of our treatment with them to re-engage them, to rescreen, to re-talk. And then patients really started to get this. This is a kind of wonky slide, but I put it in here because you hear a lot about right care. And what we defined as right care were these 3 things on the right side here. So referral to mental health care, right? An appointment to seek care, and then receiving a 1-week follow-up phone call from us. So numbers 1 and 3, we could do all by ourselves. And we did great. We hit those about 99% of the time. You know, we were really diligent and we did a good job there. But number 2 is the patient's responsibility, right? And so we were kind of low there. Again, as I mentioned earlier, when we just gave them a referral for a therapist and a support group, they weren't going. And what helped them go was sitting with them and spending that extra time with them. And as you see, once we implemented that shared decision-making tool, which is highlighted in the yellow there, that menu of treatment options, women started to go. They started to see value in that. They started to have buy-in. We kind of even out there at the end of this project, but what you don't see is that we continued this project for a few more PDSA cycles after we were done here. And all the women that we screened and that were positive right around PDSA cycle 3, they actually all went to either a support group or they went to a therapist. And so I thought that was really neat and very powerful. So our team, just like I told you, the huddles worked, the lunch and learns worked, but it wasn't until we really had them teaching this that we were over the top, and that we felt that we had a really engaged and empowered team. So enough with the run charts and enough of my neighborhood. Let's expand. And I use this term wide neighborhoods for those of you that have gone to FNU or faculty or who are there now. You'll know that's from Mary Breckenridge. And so how do we get out there? How do we, expand like that banyan tree, right? Right before I finished the DMP, because I presented and I still had a little time, so I created a toolkit with the help of the other board members from my Maternal Mental Health Coalition that had national information, national guidelines in there, like the safety bundle and screening tools, and had the local tools that I used in my office that I found really helpful, that were based often on national tools that we tweaked for office settings. And we put those all together, and we put those things together along with other things like, what do you do when you get a positive screen? Maybe here's some talking points, and here are, viable areas in our community that you can refer to. So we put this all together, and then we started to, get it out there. In putting it together, we asked for provider input, though. We went to a few OB committee meetings at the different hospitals, and we asked providers, what do you need? And so a lot of them didn't know how to bill. That was a biggie. And so we put billing codes in there and diagnosis codes, right? Or ICD-10 codes, encounter for screening. We didn't put any of the diagnostic ICD-10 codes in there. We left that to the therapist, but that's something that we can definitely put in future iterations. But we also put, what do you do when you get a positive screen? And what do you say? So if you look at this was a lot of provider input, and then we adapted these from different existing things like MCPAPS and 2020 Mom, about how to go through this algorithm of what, when you get a 10 or when you get a 12 or when you get a 14 on this EPDS, what do you do? What do you say? And then we realized that red one back there, call 911 or refer to behavioral health or the crisis team. We thought, well, geez, does the crisis team know what to say? And does 911 know what to say? You might recall, if you know, or if you keep up with this subject, a few years back, a nurse practitioner was seeing a patient in the office, and the patient had some thoughts of self-harm, and the nurse practitioner called emergency services, and they came and took the woman away. And at the end of the day, the patient did not get the care that she deserved to get. And the nurse practitioner didn't really know, exactly what to do either. And neither did the emergency EMS. So we thought we should go and we should have a dialogue with them, because if we're telling our providers to call the crisis team, we should get out there and make sure the crisis team knows what to do. So we asked for a meeting with them, and they were so kind, and we were able to go in and give presentations to the crisis team in our county. And we were able to consult with the crisis intervention officers team and give them information and PowerPoints for their staff to give at their meetings. So there's still some more work to be done, but now at least the folks that are going to be called in case of an emergency with a mom experiencing a PMAD possibly have some baseline knowledge about what to do. So that's a first responder collaboration right there. And then finally, we wanted to look at other community agencies that had contact with these moms to make sure that, they knew about us and they knew about PMADs. And the one place that came to mind quickly was the local Breastfeeding Coalition. And so we presented for them at one of their board meetings. We're cross-linked on each other's websites. They're very familiar with the different medications that are often used in this and how it can affect breast milk and transfer to the baby. So that community agency collaboration is key. We also have done a few more collaborations with other community agencies that have to do with women and children. This is just an example of one, but really getting out there and making sure that everybody's on board, and that makes this so much more powerful. So we have disseminated about 50 toolkits. And before we did that, we had to raise a lot of money. So we had some fundraisers, but we've gotten 50 out there, and the information's up on our website if anybody wants to print it out too. We've given them to 3 major county clinic systems, and they have about 33 sites between those 3. And then we have 3 large medical groups in our community, 2 of which are UCLA. You might have heard of them. They're here on the West Coast. And then Dignity Health. They're also in the western portion of the United States. So we've given these to their providers and done some education. And then multiple private OB providers have been given this toolkit as well. So they have what they need to do this. And now we go even bigger. And this is one of my favorite things. And again, when I was asked to present during this midwifery portion of the virtual events, I was honored. And I really thought, how can I talk about how we as APRNs can really collaborate all together, even though our disciplines oftentimes are different? I mean, I I'm overlapping a lot with what folks in the midwifery world do. But, still, I mean, how we all, I think, touch moms and babies and families. So how can we collaborate here? I have a dear friend, her name is Paris Malouf-Burry, and she's a certified nurse midwife. She graduated also from Frontier in 2018. She and I sat on the Breastfeeding Coalition of Ventura County together for a few years. And when she moved up north into Northern California last year, she called me and knew I was doing some work with perinatal mental health and knew that I was working on this for my DMP project. And she said that she wanted to replicate that in her area. So we consulted, we collaborated on best ways to come up with that and do that. I gave her the toolkit that we use down here. I let her watch my presentation, which is, in the depot and FNU. And she works for a large medical group up there. And to date, she has about 6 counties with all the OB providers that are implementing screening, brief intervention, referral, and follow-up with their patients. And so she's still in the implementation phase of it and still collecting data. And we're working together to see how her project is going and hopefully be able to present how just 2 people, right, can, with passion, can bring in other people from our neighborhoods to really move the needle, to really change things. And we were just talking on the phone the other day about how we felt that we were really, really fortunate to be able to have this passion for one, but then to have other people want to help us so quickly with these things. And the last slide that I have for you is this is one of the most beautiful pictures to me. This is a walk that we did in conjunction with 2020 Moms, a national agency that works to really close gaps surrounding perinatal mental health. It was called their Color Walk. I think we had the largest in the country. We had over 70 walkers last year. And many of the women in this picture and men have been affected by PMAD and were some of the folks in my project and who've been touched by the community work that we've done. And I'm Native Hawaiian, so I always try to infuse that in everything that I do. So I have this saying here, which is one of my favorite sayings, "A'ohe hana nui ke alu ia." And that means that no task is too big when done together by all. And so, again, with that passion, just a few folks can infuse an energy in other folks around them. And it's my hope that as long as we have these tools, and then we do, because you're here, you're watching me from, this FNU platform, and I know I got the tools there that I needed, and this passion, we can engage others around us to really make bold and impactful changes. So with that, I'd like to say mahalo nui loa for inviting me in today and for watching my presentation. And I am recording this, but I am available for consultation. I consult all over the country on ways to engage in the community surrounding this, on ways to start your own coalition if you want to. And if you just have general questions about how you might do this in your office, please don't hesitate to contact me. The toolkit is also available for download for free on the Maternal Mental Health Care Coalition of Ventura County's website. So you can go there if you'd like to as well. Again, I look forward to hearing from you if you have any questions. And thank you so much for your time. Take care.